So good afternoon, everyone, both home and abroad. We are welcome to another Nigerian Association of Medical Physics webinar. This afternoon, we'll be looking at radiobiological considerations in radiotherapy by Dr. E.O Oyekunle. So, next slide. Dr. Oyekunle is a clinical medical physicist of 17 years with primary commitment in radiotherapy. His doctoral work completed in 2015 was focused on optimization and dosimetry in high dose rate brachytherapy. He rose through the ranks from 2006 to become an assistant director in 2018 at the University College Hospital, Ibadan, Nigeria. Dr. Emmanuel is a fellow of the International Atomic Energy Agency, IAEA, European Society for Radiotherapy and Oncology, ESTRO, and a member of AAPM, American Association of Physicists in Medicine, and he was elected as Vice President of NAMP in June 2021. He has participated actively at several conferences, both at the national and international levels. His variety of publications cut across African Journal of Medical Physics, Journal of Contemporary Brachytherapy, Journal of Applied Clinical Medical Physics, and Journal of Clinical Oncology, among others. He is currently a scholar at the University of Liverpool and at the Clatterbridge Cancer Center, United Kingdom. Next slide. All right, so without further ado, I would like to present to us Dr. Emmanuel Oyekunle. So go ahead with his presentation. If we have any question, please, let's just put it on the chat. So after the presentation, we can read it out, and we can give some of us permission to read out our questions ourselves. Over to you, Dr. Oyekunle.
Good afternoon, distinguished colleagues. Can you all hear me?
Yes, we can hear you.
Yes, we can.
I'm so pleased to be here this afternoon to have this chat concerning this topic, which I consider very relevant to radiotherapy in a bid to improve the healthcare we deliver to the patient we care for. I'm so pleased to join us once again on this webinar. I'm highly delighted. I really wish that other physicists will find time to join as well. But if not, I believe they will be able to follow up through the recorded copy of the webinar. So radiological consideration in radiotherapy. My name is Emmanuel Oyekunle. Presently, I'm a scholar at the University of Liverpool and the Clatterbridge Cancer Center, UK. So I believe there should be some learning outcomes that need to be achieved by the end of this webinar, by the end of this discussion. And I've set out a number of outcomes, such as what radiobiology is and the associated parameters. We have a need to understand fractionation in radiotherapy, especially based on the linear quadratic model. There is a need to understand the applications of the AQ model in both external beam radiotherapy and brachytherapy. We also have a need to distinguish between treatment interruptions and retreatment, which will warrant radiobiological consideration, and also examples of treatment interruptions and retreatment. So to start with, in order to achieve these outcomes, I believe there are outlines that need to be achieved. I mean, outline that we need to go through. So this outline also are similar to the outcomes. So I'll be going through a number of slides. I will try as much as possible to maximize time. I will enjoin us to kindly defer questions to the end of the presentation in order to maximize time, so that I will be able to cover the entire slides because I believe each of the slides has important information regarding this important subject. So what radiobiology is, the parameters, LQ model, justification for fractionation based on the LQ model, the applications of linear quadratic model, what can we consider as radiotherapy interruption, what can we consider as a retreatment, the radiobiological advice that we could offer for treatment interruption cases, radiobiological advice for retreatment cases, take-home message references, and questions. So as I said earlier on, radiobiological considerations in radiotherapy is a very important issue that is actually of interest to anyone practicing radiotherapy. I found radiobiology to be one of my favorite issues in radiotherapy, and especially I believe that this is one area where we really need to improve on in the Nigerian setting because we know the challenges we have with respect to patients coming back for treatment, and also because of high rate of interruptions that we experience at our various clinics. So I believe that this subject is of high essence because it will help to improve the quality of healthcare we deliver, as we will see as we progress. So to start with, what is radiobiology? So radiobiology is simply the effect of radiation on biological systems. So we know that radiation could be ionizing or non-ionizing. So when there is an interaction of radiation with biological systems like the human body, there is a sure tendency of experiencing interactions and experiencing different degrees of damages. And so this damage could be direct if sufficient energy is delivered to deoxyribonucleic acid bonds, which we know that it goes for life, is a fundamental structure, atomic structure in the human body, which will also guide the metabolism of the body and what happens in a lifetime of an individual. So when there is a direct damage, it shows that sufficient energy has been delivered to break the DNA bonds sufficiently. And this we call double strands break. So indirect damage often occur outside the DNA, and that could result to maybe sublinear damage that could be repaired. So the most common of these is when we have water interacting with radiation in the human body. So when we have water interacting with radiation, we have water interacting with gamma radiation. So this gives the hydroxide, hydrogen and hydroxide ions. And if this hydroxide come very close to the DNA, then it will cause damage to the DNA, and that is what actually happens in destroying the cancer cells. And we know that radiation is a paradox. Radiation could cause cancer cells to be destroyed and could also induce cancer cells. So radiation definitely has two sides, but the beneficial aspect of radiation, ionizing radiation, is the fact that it could kill cancer cells and help us to treat tumor. So this is just a good example of the DNA strands. So we have the single strand break, as we could see a break just at this point. And here we have double strands. So we have the two strands. A break has occurred here, a break has occurred here. So we have double strand breaks, and we also have it here. So definitely it is easier to repair the single strand break because the damage is sublinear and it could be repaired. And we know repair is one of the 5 R's of radiobiology. So definitely there's room for repair, but in this case, double strand break repair is very difficult, if not entirely impossible. So definitely the double strand break will help to kill the tumor cells, and that is what radiation does. So there are some key terms or parameters that are of importance in order for us to understand the concept of radiobiology. The first one is the total dose. which is the overall prescribed dose for radiotherapy course. For instance, we could have 65 gray to treat head and neck squamous cell carcinoma. We could have 55 gray in 5 fractions to treat the lung using stereotactic ablative radiation therapy. We could have different types of fractionation doses. So you could have 60 gray to treat prostate. You could have 45 gray to treat small lung cancer. So the total dose is of importance. The fraction size represents the dose per fraction, the dose that will be delivered for each fraction of the treatment. Number of fractions represent the number of treatment over which the total doses will be delivered. So we have repair. So the 5 R's in radiobiology, we have repair as the first one. The two most fundamental R's are the repair and repopulation. So tumors and healthy cells could both undergo repair from cellular damage. But we understood from the concept of radiobiology that tumors have slower repair from effect of radiation than the healthy cells. And that is why healthy cells could benefit by having time to repair interfractions. So repopulation, yes, repopulation is a very important concept, and it has to do with the tumors, because definitely tumors will repopulate with time. The tumors, they will experience cell division and repopulation growth interfractions from one fraction to the other. And that is the reason why it is really helpful to have fractionation, so that with fractionations, we know that tumors which can repopulate, it will help the normal organs especially to recover from the effect of radiation. But tumors will definitely grow, but the effect of repopulation will be pronounced, especially when treatment is so prolonged. When treatment is so prolonged, repopulation will be minimal within fractions, interfractions. But when the treatment duration is prolonged, then there is a high tendency for repopulation to accelerate, which will not be in the interest of radiotherapy. So another concept is redistribution. Redistribution also has to do with interfractions, different distribution of the cells within a given cell circles. So in a particular, let's say the mitotic phase of the cell circle, you could have cells distributed in a particular pattern, but definitely across the fractions, the distribution will change with time. And that is also another factor that could affect another concept, but to a minimal extent as compared to repair and repopulation. Reoxygenation. Tumors are generally anosic, they are hyposic, so definitely they are short of oxygen, and because of that, they are more radioresistant. And so because they are more radioresistant, it is helpful that we are able to fractionate so that some of the tumor cells that have been killed with one fraction of radiation will give room for other cells that are remaining to have access to radiation. So the proportion of oxygen that will be available to the remaining cancer cells will help those cancer cells to die from irradiation. So when some tumor cells die between fraction, oxygenation is enhanced for the rest, and that continues across the fractions. So reoxygenation is also important because it helps to improve radiosensitivity, make the tumor cells more sensitive to radiation. Radiosensitivity has to do with the different body organs in the body. In the body, we have the serial organs, the parallel organs. The serial organs are more sensitive to the maximum dose that is delivered, such as the brainstem, the spinal canal, the optic structures. Those are serial organs. The parallel organs, we have the lung, we have the liver, we have the kidney. So these parallel organs, they will respond to radiation based on the volume of the organs that have been irradiated. But with respect to the serial organs, maximum dose is so crucial. And that is why we often talk about the dose constraint for spinal canal PRV as a good example. So radiosensitivity depends on the body organs that is irradiated. A very good example of cells that are very radiosensitive, which we need to be mindful of, are the hematological cells. And that is why we know that bone marrow, for instance, is very radiosensitive because it has to do with hematological physiology in the human body. So neurons and sarcoma, melanoma, those ones are radioresistant. Another important concept that needs to be understood is a biological effective dose that shows the biological effectiveness of the dose, that is the impact of the dose in the body, how effectively it is able to cause, the physical dose is able to cause radiation damage through the DNA. The equivalent biological dose is when we normalize the BED to 2 gray per fraction. So in continuation, we also have therapeutic ratio. So therapeutic ratio helps us to understand the effectiveness of radiotherapy in terms of cure and also in terms of the undesirable complication. So the probability of cure for the tumor and undesirable complication for the normal tissues. And we could actually explain this concept in terms of when we have an equal dose, when there is an equal dose given for a particular dose, if we evaluate the level of damage to the tumor, we compare it to the damage in the normal cells, then we could assess or determine the therapeutic ratio. Alternatively, we can also assess therapeutic ratio by considering what dose delivered to the normal cells, the ratio of the dose delivered to the normal cells and the dose to the tumor cells, that will give an equal effect, give an equal level of biological damage. We can also assess therapeutic ratio in this way. So yes, importantly, the linear quadratic model, this is also known as the alpha-beta model. And this model was derived by Withers and co. when they experimented in vitro in order to see how doses will affect reaction or response, and also to see how the relationship of dose will be with respect to cell kill. So we have this S as a surviving fraction of a given dose, and we have this function, we have alpha D minus beta D squared. So this is a linear part of the kill, cell kill, and this is a quadratic component. So the alpha D actually represents the probability of cell death when there is a single double hit. So the probability that when there is a single double hit is going to cause cell death. So this will be due to high linear energy transfer radiation, ILET radiation. The beta D square has to do with when we have multiple single hits, as shown in the earlier picture, whereby we have single hits. So when we have multiple of them, definitely the process will be slower. So that is a quadratic component, which will be a slower process of cell kill. So the linear process, the linear part of this of the curve of this cell survival curve, and also the quadratic part. So the summation of these two effects gives us the leader DNA abnormality. So a good way to illustrate it is using this particular image. So when there is a low dose per fraction, for instance, definitely it will cause this low dose per fraction in this region. So low dose per fraction is something that will be experimented or implemented in radiotherapy when we have hyperfractionation, for instance. Hyperfractionation, let's say you are treating head and neck with 70 gray in 35 fractions, 60 gray, 65 gray. Definitely you have 30 or more fractions. So with low level of dose per fraction size, you have many more fractions. So definitely the high alpha beta tissues, they will be damaged. So high alpha beta tissues will be damaged, and high alpha beta tissues such as the head and neck, and that is why hyperfractionation is practical, relevant to head and neck treatment, because the head and neck areas is known to have alpha beta ratio of 10. So definitely it will be easier for it to be damaged because of this impact. So with low dose, we have high impact of cell kill, we have high level of cell kill, and Alternatively, or let's say conversely, the low alpha beta tissues, they will be spared. So in the hypofractionation regimen, so we have the high alpha beta, they will be spared. The reverse is the case because in this case, we have high fraction size, high dose per fraction, and fewer number of fractions. So definitely hypofractionation will favor the low alpha beta tissues, such as the prostate, for instance, and also the breast. So definitely hypofractionation will be more relevant for that. So this is a good illustration of the cell survival curve. We have the linear part, we have also the curve part. So the linear part represents the alpha, where we have double hit and double strand break, and where then we have the quadratic parts that represent the multiple single hit, contributing to this to cell kill. So as I said earlier on, alpha single hit kill, unrepairable damage, and this will not depend on fractionation. Irrespective of fractionation, if the dose is high enough, and if it is of high linear energy transfer, like proton, and we have proton, we also have carbon ion, we also have other proton therapy, definitely we will have easier, higher degree of damage. The beta represents the factor, the probability that takes care of fractionation and dose rate when you have multiple hits. So when we say alpha beta ratio, we are all familiar with alpha beta ratio. What we mean is that a alpha beta ratio of, let's say, 3 or 10 or 2 means the dose when the kill arising from alpha and the cell kill arising from beta are equal. So when these two levels of kills are equal, then we could say that, okay, that is the alpha beta ratio for that particular tissue. That is the dose, let's say 3 gray, 10 gray, 2 gray, at which the contribution of alpha and beta to cell kill are the same. Then that is the alpha beta ratio. And also it helps to illustrate or to indicate how resistant a cell will be to radiation damage. So we have the low alpha beta ratio. In such case, we have high repair. So high repair could be experienced in low alpha beta ratio tissues. Like I mentioned earlier, a good example one is the prostate, for instance. And that is the reason why prostate is recommended with alpha beta ratio of even as low as 2, because we know that in this case, we could have hypofractionation could be of help. So the small fraction size will cause tissues relative resistance. Large fraction size will cause tissue sensitivity. So with small fraction size, that is dose per fraction, there will be relative resistance. But with large fraction size, that is when we have high dose per fractions, then we have sensitivity to radiation. So we also have the high alpha beta ratio, like the head and neck, so low repair. So, and that is why in head and neck, for instance, small fraction size will be recommended because there's a lower degree of repair. And definitely with this, we have tissues relative sensitivity will be high with small size. And then for the large fraction size, there will be tissues will be relatively resistant. How does the LQ model justify fractionation? So it justifies fractionation in the sense that tumors that have high alpha beta ratio, tumors generally have higher alpha beta ratio than normal tissues. So if tumors have high alpha beta ratio, such as 10, for instance, then we know that the normal tissues that have a low alpha beta ratio will be spared when small fraction sizes are used. So late reacting tissue like the CNS, they are sensitive to fraction size. So we could say that there's a limited benefit from fractionation for low alpha beta tumors, such as prostate. So fractionation times that are used, we have standard fractionation. Ideally, we should have like 2 gray per fraction or less. That should be the minimum, 5 days in a week. It's just unfortunate that we're in the Nigeria setting, we have maybe some hospitals not able to treat on a daily basis. this is really not favorable for radiotherapy, because we are running the risk of extending the overall treatment duration, and also considering the fact that repopulation is practical in tumors. So the standard fractionation will be 2 gray per fractions once daily for 5 days a week. We could also have accelerated fractionation, whereby you could give more than 10 gray a week. So in such a case, you could have maybe more than 6 days treatment, 5-day treatment, maybe 6 days or 7 days, Monday to Friday, probably maybe Saturday and Sunday, in order to be able to have more than 10 gray in a week. So these are just fractionation terms, which I will refer to later. So we have accelerated fractionation. We also have hypofractionation, like we have the high fraction size, such as maybe using 11 gray in SABR, for instance, 11 gray times 5, 55 gray in 55 gray in 5 fractions, or we can have 54 gray in 3 fractions, that's 18 times 3. So, which is very useful for SABR lung, which will be also delivered in less than maybe 5 fractions, maybe 3 fractions, 5 fractions. That is hypofractionation, a very good example. And hyperfractionation is when you have reduced the fraction size. You have made the fraction size to be of greater than 1 fraction a day. That is, it is reduced, but you have more than 2 fractions a day. For instance, you have one fraction given minimum of 6 hours after the other. Why I'm considering these fractionation times is because of some practical problems we are going to see soon. So let's look at application of linear quadratic model in external beam radiotherapy. So this is a problem. For instance, a patient presented for radiotherapy of the spine, and he or she is to be treated with 3 gray daily fractions. So what limit, measure, what constraint, what advice would a medical physicist recommend such that the spinal cord, that should be alpha beta ratio of 2, will receive dose that is equal to 98 gray or less? So this patient is receiving radiotherapy to the spine and is to be given 3 gray daily fractions. But the goal, probably certainly as recommended by the clinician, is 98 gray biological effective dose. That too there represents the alpha beta ratio for spinal cord for the critical organ matrix. So 98 gray is the maximum, the limit. So how is this treatment going to be delivered? So using this Witter's formula for BED, where we have N is the number of fractions, dose per fraction, and all this. So I suppose we give the first 3 gray. The first 3 gray, that is the first fraction of dose. So the first fraction of dose, the BED, so N is going to be 1 in this case, D will be 3, and then D here is also 3 gray. Alpha beta ratio has been given as 2. So if we put this together, that will give us, this will be 3 divided by 2, 1.5 plus 1, 2.5, 2.5 times 3, that will be 7.5. So we could readily say that 1 fraction of the physical dose of 3 gray will give rise to biological effective dose of 7.5 gray in the patient. So the number of fractions, so now we know that 1 fraction will give 7.5 gray. So number of fractions that will help us to give 98 gray will definitely be the total, that is the limit that we have set, 98 gray BED, which ideally the clinicians should have determined beforehand. And I believe that a good thing to do will be for every hospital to have protocols of constraints, not just in terms of the physical doses, but also the biological effective dose. This could be in line with established literature, clinical evidence, so that when we plan treatment and we do calculations, radiobiological calculation, we tailor our calculations, our evaluation towards a particular protocol for different body sites. So if we have 98 gray set as a standard BED for a protocol in a hospital, then you say, okay, using 3 gray daily fractions, we have 7.5 gray BED per fraction, and then the number of fractions arising from this will be 13 fractions. Then we can say that, okay, 13 fractions is what will be related to 1 fraction of dose of 3 gray. And in order to give 13 fractions, we have 13 fractions, and then we have 3 gray. 3 gray, that is the daily physical dose, daily fraction dose. So 13 that we have obtained multiplied by 3, 39 gray. Then we could say that, okay, for this patient, the physical dose to be delivered is 39 gray. And that is how we can arrive at, okay, this is a physical dose to deliver in order to achieve the 98 gray BED that has been set for that particular organ at risk. So that is a practical example of the application of BED in order to determine the physical dose that should be delivered. So the physical dose could be derived from the BED based on the limit that has already been set beforehand, according to a protocol for a particular organ. This is another good example to consider. A patient is to be treated for lung cancer using 2 gray fractions for a total dose of 60 gray. So 60 gray to be delivered in all using 2 gray per fraction. So if the first 5 fractions are given at 3 gray per fraction due to SVC syndrome, on the assumption of alpha beta ratio of 3, alpha beta ratio there, what additional dose would you advise for delivery at 2 gray per fraction? So we are to give 60 gray in 2 fractions of 2 fractions. So definitely the total number of fractions will be 30. So that we have 2 gray per fraction multiplied by 30, that will be 60 gray. First fractions delivered at the rate of 3 gray per fraction. So at times you have a prescribed dose to be delivered, a prescribed dose for certain fraction size, dose per fraction. But situation may arise whereby you want to start the treatment with a higher dose per fraction, like 3 gray as to 2 gray, and then you want to see how are you going to continue the treatment. So definitely the clinicians, they have the goals in mind, but definitely one of the important tasks of a medical physicist is to be able to provide radiobiological advice as to what will be the impact of a particular fractionation, how fractionation could be altered, what will be the detriment to the organ at risk, how effective is it for the target, and be able to give the clinician options to choose from. So the clinicians will assess these options and will be able to take a final decision. We know that the primary task, one of the primary tasks of a clinician is to decide on the treatment regimen because of the fact that they see the patient, they are able to assess the tumors and the likes. But we have a very important task in our hands to do, to provide guidance and give them evidence of the guidance that we are providing. So using this AQD2 formula, we could have this, that, okay, 5 fractions of 3 gray. The patient has received 5 fractions of 3 gray. So definitely the EQD equivalent dose here will be 15, 6/5. If I go back to the previous, so definitely we have it here. So we have 15 multiplied by 6/5. Oh, sorry. So we have this, so that will give us 18 gray. So we could say that using that formula, we have 18 gray, and then if you subtract 18 gray from the 60 gray, total of 60, we have 42. So we wonder why are we using EQD2 here? So a very practical use of EQD2 is when you want to evaluate what will be the biological effective dose when the dose is given in 2 gray fractions. Remember that it's stated here that 2 gray fractions of that dose to be given in 2 gray fractions. But we have started the treatment using 3 gray. So how are we going to find the equivalence of the effective dose in terms of 2 gray? Because we have given treatment in 3 gray per fraction, but it's to be given in 2 gray. So this 3 gray per fraction for 5 fractions has given us 18 gray. So that is the equivalent biological effectiveness in terms of 2 gray, which is actually what we want. So that is why we're able to subtract 18 gray from 60, because that 60 was intended to be given in 2 gray fractions after all. So the total 42 gray, and then we can now say, okay, 42 gray left. Then we have divided by 2 gray per fraction, and then we arrive at 21 fractions. So we could say that, okay, this will be the additional dose, the way to continue the rest of the treatment. After 5 grays of 3 fraction, then we have this. So that is a very practical example of how EQD2 could be applied. So let's also quickly look at LQM model in when we combine external beam radiotherapy, that is teletherapy, with brachytherapy, which is very important because we know that in Nigerian setting, we have a lot of cervix cancer patients, and definitely the best approach would be to combine external beam radiotherapy with brachytherapy. But how often do we consider the treatment dose that has been delivered through external beam radiotherapy? Do we take into consideration the biological effective dose that the organ, artery, the rectum, the bladder, the sigmoid have received from external beam when we are planning brachytherapy? This is a question for us, and this is something that we need to look, we need to aspire to do in order to limit toxicity to these organ arteries. So let's say we want to give dose to a particular patient, and then the reporting protocol is ICRU 89 minimum standard of reporting in brachytherapy. But there's a particular question here which I want us to quickly go through. So for a 2D radiograph base, which I know different centers could have started with 2D radiograph base based on limited facilities. If the pointed dose is said to be 85 gray, so 85 gray is set as the 85 gray or more, that is minimum of 85 gray. The rectal point is more critical. It's a more critical organ than the bladder, less than 70, and bladder 70. So if a standard plan is performed, and in that plan we have pointed dose given as 7 gray, let's say 28 gray in 4 fraction, 7 gray. The rectal dose, we're able to achieve less than 5 gray, bladder dose less than 6 gray. So let's see what happens. So, okay, we have the alpha beta ratio for the pointed, rectal dose, and bladder dose. Now, let's see how we apply this EQD2 to see what actually happened. So I created this spreadsheet just to illustrate how we can match the external beam phase of the treatment with the high-dose straight brachytherapy phase. So that this very patient has received a total of 45 gray, which is standard radical dose for cancer of the cervix. So we have 45 gray in 25 fractions. So definitely the BED, we have this, and the EQD2 using this formula up here. So then we get, definitely, we always have higher values, numerical values of the BED and the EQD2. So these two values definitely will be higher than the physical dose. So we have the EQD2. So this will be the equivalent if the dose has been delivered. That's just the implication. So instead of delivering this dose in 1.8 gray per fraction, if it has been delivered in 2 gray, then definitely we have this. So we have 44.3, and then this is 2.1. That is a biological effective dose arising for 1 fraction. So definitely, so we have 53.1. So going down here, we have the doses arising from brachytherapy. And looking at these doses, we have the total dose. So we have 39.7. So we could say altogether, this patient has received total EQD2 of 44.3 plus 39.7. So, and that will give us like 84 as a total. So, and then this is for, we have this for the rectum. So in this case here, we just change the alpha beta ratio to 3. So we could see that we are trying to account for what the patient has received from brachytherapy, even to the rectum. So by just changing the alpha beta ratio from 10 for tumor to 3 for rectum, and also for bladder, we do same, also 3 for bladder, so that we'll be able to say that, okay, this is the biological effective dose and the EQD2 that have resulted from external beam. So that will be added to that arising from what we're able to achieve from our plan. So this 6 gray, for instance, is what we could achieve from prescribing to point A using 2D based approach radiograph. We're able to create a standard plan, and then beforehand, before treating, using the radiographs, we're able to determine the ICRU doses, that point doses to the point A, rectal point, bladder point, according to ICRU protocol. So if you have 6 gray, so 6 times 4, and then we have the total BED and EQD2. We need to add it to that of the external beam. So there should be a spreadsheet beforehand that will be able to take into consideration, okay, this is what we have from the external beam dose, and then we add to that. So how are we going to apply this? Yes, so we have 0.8 dose of 7 gray ICR dose. These values are based on the standard plan using radiographs, 2D approach, without the use of 3D images from CT, MRI. So we have alpha beta ratio from them. The intention will actually be to deliver EQD. These are EQD doses of greater than 85, 70, and less than 80, less than 70. So looking at what we observed earlier on, that we have 84. We achieve 84 EQD2. That is combining for both the external beam previously done, or still in previously done, and then for the brachy. So we have this. What can we say about this outcome? Is this outcome, is it acceptable? Will it be reasonable, so reasonable to the clinician? I believe the answer is no, or will be no, simply because we have exceeded the tolerances for the rectum and the bladder by, so the mere fact that we create a standard plan and we say, oh, we get 5 gray, 6 gray, both of them are less than 7 gray for the point A, does not mean that, oh, we have done the best, we have achieved our goal. The EQD2, the biological dose or the doses compared to the intentions. And that is why intentions should be defined in protocol beforehand. I mean, our treatment should be tailored towards a protocol, which will be a standard. It will not be just for different oncologists to have different views, use different dose prescriptions. We should have a protocol for each clinic, for each clinical setting hospital, of our intentions set beforehand, to which we will tailor our treatment, our planning, in order to achieve the best for the patient. So a good approach here would be to do what? If this case, this patient is a patient that has small residual tumor, that is a patient that has responded very well to external beam. So that is why it is the clinician that is going to take a decision in this case. So definitely the clinician will not accept this one in red, this EQD2. So if you are able to reduce the dose to point A, let's say you are able to reduce the dose to point A, you reduce it maybe from 7, you bring it a little downward, maybe to 6.5 or something less than 7, and then you go back to that spreadsheet, you reevaluate, and you get 76, and then you have 6980. Because definitely when the dose to point A is compromised, the doses to the nearby OA house will also drop. I mean, the physical doses. And by implication, the EQD to BED will also drop. Mind you, remember that we are still considering that of the external beam. What they have received from external beam also are being factored in. So if you have these values, I believe this value will be acceptable only if the patient have more or less complete response from external beam. So if the tumor is small and the response have been good from external beam radiotherapy and all that, we could say that, okay, even though this 76 is smaller than 85 gray, because the intention would be to have those EQD2 greater than 85 gray. So even if 76 is smaller than what was set point A, we will accept it because the residual tumor is small, the tumor has responded well to external beam, then there's a high tendency for it to respond well to brachytherapy with this dose, even though it is less than 85 gray. And then we are so happy that 69 and 80 before within our intention here. So this will be acceptable. But if it is a large residual there, if the tumor is still bulky, even after external beam, and the clinician struggle to put the applicator, definitely we cannot accept this because we are compromising those to the target. So in that sense, we have to advance to a better approach. And that is why the beauty of doing brachytherapy will actually be to use a three-dimensional volume-based approach whereby we have volume imaging and plan according to that protocol. So let's say we have a different scenario whereby the prescription, this is 3D based approach for the same patient. So let's say for this patient, the patient is found to have bulky disease after external beam, and then we have these goals to achieve. So after creating the plan, let's say we have 9.2 to the CTV, 5.7, 8.6, we have this. We also have this. These goals, these ones are just as what we set for the 2D based approach, but this time around we are looking at the doses to volume, 2 cubic centimeter volume of rectum and bladder, and then D90 HR high risk clinical CTV, HR CTV. So we have that clinical target volume. So definitely we have, if you have 103, 83, 123, so we could see that this is not acceptable because organ arteries are well outside tolerance. So it will be good if this is modified, if you're able to bring down the physical doses to 6 for the HRCTV, and then this comes down, and then we have this. So overall, if something doses as low as this achieved, we have this pattern of doses whereby, okay, we have these are within the tolerances, and then we have 76. So we have 76, not so acceptable because HRCTV will be compromised. So, but we could have this could be accepted if there is an indication that, okay, the implant could be done. And that is why also radiobiological consideration will be easier to do if a good implant therapy. A good plan will start with a good implant. So if the implant is already bad, I mean, wrong placement of needles, wrong selection of applicators, it will be difficult for physicists to optimize. So physicists will not be able to optimize a bad implant. A bad implant is a bad implant, a bad application. That is the applicator size and the features and how they are positioned. It will be difficult to get a good plan. But if the implant is good and reasonable, it will be easier to optimize. So it is always good to consider the EQD2 with respect to external beam also. So in such situation like this, a step forward, because in the previous one, this is not so acceptable. So in this case, we have the doses reduced. Here we have 9.2, 5.7, 8.6. So if the doses are brought down from 9.2 to 7.9, and we have this reduced, so we have this goal or these values. So these values definitely, they are well acceptable. I believe any clinician will be so glad to have this because these fall within the tolerances, and 91 just greater than 85. So much better than having 103, of course, helping the targets, but these are way too higher than the set doses. So interruption definitely is when a patient has made some fraction during the course of radiotherapy, and then we have concerns for both the tumor and the organ at risk. Of course, because the tumor, because definitely there's going to be repopulation if the treatment time is extended. We have retreatment. Patient has been treated for a while, and then patient returns after 1 year, 2 years, 3 years, whatever year for treatment. So a pertinent question to ask is, in Nigerian setting, which is more common in the Nigerian setting, and which one is easier to address or manage? Is it treatment interruption, or retreatment? Maybe I'll leave that to be answered in the end, but these are two practical cases that could occur. So I'll quickly go to a particular scenario. A head and neck patient has missed 7 fractions of treatment. The missed fractions were 5 in the 3rd week. So 3rd week of treatment, 5 fractions missed. Another 2 fractions missed the following week, Monday and Tuesday. Treatment was decided to resume on Wednesday of the 4th week. The prescribed dose is 65 gray in 30 fraction. What would you advise? So the way to go about it is to consider this formula. This is an extension of the initial weighted formula I provided earlier on. In this case, we are taking into account repopulation factor, whereby we know that for every single delay, a day delay in treatment, interruption of 24 hours, a day delay, there will be a loss of 0.9 gray BED will be lost due to 1 day delay in treatment. So, and then from studies for head and neck, because of hyperfractionation regimen and because of the fact that it is a very aggressive type of tumor, so definitely using that, we have 28 days. That 28 days is actually the threshold when we begin to have rapid repopulation. So definitely, so the overall treatment time that the treatment has taken is a T. Then you subtract it from the time delay, that's 28. So we have this to consider in order to solve this problem. So these steps are the steps to follow. What is the original tumor BED that we intended to achieve based on that prescription that the clinician provided? What will be the tumor BED with the gap? What is the tumor BED that had been delivered? What will be the remaining BED that we need to work towards to? And then apply the linear quadratic model to generate a quadratic equation and solve for the dose per fraction using that equation, using the right alpha beta ratio. So to solve this problem, I designed this just to show us. So a practical case, which I believe, of course, as you know, is not difficult, is something we have been experiencing. I mean, some of us would have experienced that at our various clinic, interruption for 5 days or even more. So if you have treatment given first week, second week, look at the 5 fraction missed already in this third week, another 2 fraction missed. So you have 7 in all. So ideally, treatment should be completed at the end of week 6 here. So, but now we have, let's say we want to consider putting these 5 here, these 2. This will not be ideal, will not be acceptable, because overall we are exceeding the 28 days. And then repopulation will set in and will make it more difficult to manage the situation. So this is a good way to handle the situation. We have this formula. So the prescribed dose, we have 30 fractions. 30 fractions, the dose per fraction is 2.17 based on dividing the dose by the fraction size, the dose per fraction. So we have 30, 2.17. This is a dose per fraction. Now 39, how did I arrive at this 39? I need to quickly show how I arrive at the 29. So I arrive at the 29. Yes, so I arrive at 39 by counting. The starting day will be day 0. So if I count, normally the treatment should end here. So then we have 5, 5, 5, 5, 5 times 6, that will be 30. Look at the weekend. 1, 2, 3, 4, 5 weekend. 5 weekend before week 6. 5 weekends. So that will be 10. 10 plus 30. That will be 40. Remove the first day, because you start counting the number of days from Tuesday, not from the Monday, not from the starting day. So 40 minus 1, that's how we have 39. So that's why we have 39, the total time duration. That is if there was no interruption. Treatment finish at the end of the 6th week. You have 39 minus 28, the threshold. And then the original BED intended, based on that, dose and fractionation will be 69.3 gray. 10 represent the alpha beta ratio for tumor, 10. So now, if you estimate the tumor BED with gap, that, okay, we are considering the gap, that this treatment is going to, suppose we say, okay, this treatment, now we have gap, and the 7 fractions that have been missed are brought to the end of the 6th week. You know, after the 6th week, you push the missed fractions forward. Then the total time duration will increase. So if you multiply how many weekends, here you have 7 weekends. I mean, Saturday, Sunday, 2 times 7, that will be 14. So you add 14 to 30, and then that's 44. Then you add that, and then you count, and then you subtract. So if you do all that, so you have 7, 2 times 7, 40. Then we have 7 times 7, 49. So we have 5 days here. First week, 5 days. 5 times 7, that will be 35. 35 plus 14, we have that. plus that will be 58 minus the first day, because it's important to get the total duration right. So we have 57, that is with the gap, pushing the mixed fraction to the end. We have 57 instead of 39 originally intended. So so we see 59. So what has happened if we check my dear colleagues, we can see readily that there has been a drop of BED by 23.4%. Because of this interruption, BED has dropped by 23.4%, and that will reduce the biological damage expected for the tumor, thereby increasing the risk of recurrence. So what will be the way around this? So there are options. The approach actually will be that we should maintain the actual intended completion date of the treatment. So we have delivery of 20 fractions, 30 fractions in all. 10 have been delivered, 5 in first week, 5 in second week. We have 20 more to be delivered. So definitely we need to complete this on the 39th day, which will be the end of week 6. How do we achieve this? There are different options. We could say that, the first fraction on Saturday and Sunday of week 5, and then 5 by daily doses. So we could say that, okay, can we just have, if I go back to the, to this calendar. So we could say that, okay, can we just have fraction, okay, different. So let's just have treatment on weekend, and then we have treatment. So we have 7. How are we going to have? So we can consider different approaches. So different approaches just to see that we have that 7 within the days of the other treatment, so that we have bi-daily fraction. Bi-daily doses means we have 2 fractions in a given day, just to ensure that we do not push beyond 39th date. So these are the different options. But I would prefer, the most reasonable thing to do will be that we spread the fractions, maybe Fridays of week 4. We have 3 Fridays. So look at this Friday. So we have Friday. So if you have 1 treatment here, 1 year, 1 year, that will be 2 treatment on Fridays, 2 treatment. So 1, 2, 3. We have taken 3 fractions, cover 3 fractions. Then we can take Monday and Wednesday. Monday, Wednesday, Monday, Wednesday. So extra 1, extra 1, extra 1, extra 1. So that will be 4 plus 3. So that we finish the treatment at the end of the 6th week, the 7 fractions, instead of pushing them to the end. So we can have different ways of trying to spread the number of fractions, but that would be a reasonable thing to do to ensure that option 3, we are able to maintain the number of days, and then we leave the clinician to decide on which one is acceptable. But definitely there will be 6 hours in between the treatment. Another approach would be to increase the number of fractions.
Okay, please, you have 1 minute.
Okay, another approach would be to increase the number of fractions by trying to use find the tumor bed, the BED intended, what has been delivered 10 fractions, and then you calculate what is left, and then you translate that to physical dose. It's a pity time is not allowing me to go through these slides well, but definitely I'm trying to pass across some important salient points that we need to implement, we need to consider in order to improve therapeutic ratio and clinical outcomes. So if we have retreatment, I'll just quickly go through this treatment, 5 minutes, please, retreatment. So suppose a patient that have been treated for head and neck, maybe over 3 years ago, and then the maximum dose was 45 gray to 0.1 cubic centimeter in 35 fractions. So if there's need for retreatment, patient has come back and we need to retreat, what are we going to consider as a maximum dose constraint for the spinal cord, which is a planning risk volume for the new plan? So looking at literatures, we have information in literatures that, okay, if patients have received treatment before for a particular tumor site, the first thing will be, okay, assess the treatment plan, maybe on Eclipse or whatever planning system that is in use, calculate the BED using a suitable alpha-beta ratio. Let's say the BED is 75.1 from the treatment already delivered. Then we can say that, okay, if we have set our dose limit as 50 gray for spinal cord, for instance. Then we have 85 as the dose limit. And then according to Kirkpatrick, the literature, I mean, it was established that organ arteries such as spinal cord, PRV, could recover. So I could have 50% of recovery when the treatment time elapsed has been over 2 years. So we can say that, okay, 37.5 have been recovered. So definitely 37.5. So we can subtract 37.5 from the limit that we have set, and we have this. And then we could use the linear quadratic model to convert this BED to dose per fraction. And then dose per fraction multiplied by total number of fractions, we get the physical dose, total dose to be delivered. So this will be the total dose to be delivered for 35 fraction for the new plan based on this protocol. So we also have 120 gray set as a constraint. If there is no assumption of recovery, that, okay, no recovery, maybe treatment was just done less than 2 years, and we say that organ arteries still have that 75.1 gray, has not recovered. That means the BED to the organ arteries still maintained. Definitely, we can just assume that, okay, a low risk of complication to the OAR will be 120, according to this literature which I've cited. So 120 maximum minus 75.1, 44.9, and there we can determine this is the dose to be delivered, the treatment. And if we want to use the upper limit, that, okay, maybe this dose limit is low, then we can use 135 and then use this approach also. So take home message. Curative courses of treatment ideally should not extend beyond intended time duration. It's best to maintain the time duration for the intended treatment, because we will struggle to compensate especially if you have more than 5 fractions. Treatment interruption will increase the risk of local recurrence. BED calculator must be considered for OAR. So it's not just as we saw for that of the external beam and brachytherapy for cancer of the cervix. We need to estimate what the BED EQD2 for those OARs were and factor that in, not ignoring them completely. Additional fraction could be added to the end of the treatment, but few fraction as much as possible, as few as maybe 2 or 3, so that we don't run into problem of repopulation for the organ at risk. Repopulation, for the tumor. The dose could be increased by up to 10% for the remaining number of fractions. Yes, dose per fraction could increase, but it should be as minimal as possible in order to also avoid BED increase for the organ at risk. And the final take-home message, physicists should exclude bi-daily fraction for patients. Yes, if the performance status of a patient is not favorable, then it's best just not to use bi-daily fractions for such patients. The dose control for retreatment should be based on previous dose received, as said. So these 2 publications are very good, very relevant, that are used for retreatment and also for guidance in radiobiology. So alpha beta ratios, assumptions, anything you should be documented such that one could always make reference to that when patients come for other phases of treatment, or when trying to analyze, carry out an audit to assess treatment outcomes. If any organ recovery is assumed, then calculation should be done with the recovery factor applied. So these are the references, especially this, the last 3, this 1, 2, 3. And then I also have these other references. This is a textbook. I want to acknowledge the International Atomic Energy Agency, Radiotherapy Cancer Center, University of Liverpool, because I've gained some insight, more insight in radiobiology through these organizations. And I believe these insights are very fundamental to improving radiotherapy to our patients. Thank you, everyone, and my sincere apologies for running out of time.